Hello, everybody, and welcome to our webinar on social care statistics, which is being held jointly by the Health Statistics User Group and the Royal Statistical Society Official Statistics Section. I'm chair of the Official Statistics Section, so I'd like to welcome you on behalf of the Royal Statistical Society. I'd point out that this webinar has been long in planning, though it wouldn't have been a webinar when we first planned it because we started before the pandemic when we didn't do such things. But some of this is work which is put on one side by COVID or has continued despite it. And I'm very glad that it's we're finally able to return to this subject. And before handing you over to Deana Leadbetter, Chair of the Health Statistics User Group, I'd like to thank the members of our committee who've done a lot of work on the technical side to put this on, as the RSS has been become short of resources to put on webinars. So to thank Hira Naveed and Adam Galatli and George Papadopoulos. Anyway, I will now hand you over to Deana so we can get on because we've got a very full programme.
Great, thank you very much, Alison. So I'm Deana Leadbetter, as Alison said, and welcome on behalf of the Health Statistics User Group. Can we just have the next slide, please, Camille? That's great. We're very grateful to the Official Statistics Section and the RSS support team because this is quite a complicated seminar to organise. It's an even more packed programme than we usually have in this series because not having done anything on social care statistics during the pandemic in terms of presenting, there's a lot to talk about. So we want to, we've actually made this slightly longer. We normally run our webinars from 12 to 1:30, but this we're actually running until 2, so it's a slightly longer one than usual. So the next slide, please. I usually start with I need to start with a bit of housekeeping. Those people who are who've attended these before will be familiar with this. It's the usual routine. Everybody muted except for the speakers. Questions via chat, please. We will be recording and noting everything that comes via chat, even if we don't manage to respond to it. So please put comments in there. So if you have any other suggestions, so not only questions, useful links, comments, please put them in chat and we will include them in the final report. And if any of the speakers want to respond via the chat, sometimes they might do that during the presentations. So we will run through all the speakers and then pick up on all the comments via chat in the final session. We have just managed to get the recording going, so thanks very much to Adam for that. So there will be a recording of this that will be available. All the presentations and the report, including the Q&A, will be posted on the Health Stats User Group website. The presentations will be fairly soon after the event, but obviously the report takes a bit longer. So there's a lot of material in there. You don't need to write it all down and the speakers won't be able to go through everything. So expect to be able to look at it at your leisure afterwards. Next slide, please. This whole webinar series has the aim of trying to exchange information, to work together, to collaborate. So people will be presenting things that is maybe the plans that they're doing. It's not necessarily the final things, and it's presented with the intention of getting comments and exchanging ideas to improve what we're doing. So this is very much the values of this webinar series, to collaborate and work together in a very sort of respectful way. So I hope you will follow that within the chat and the discussion. Both now and after the event, if you do want to put comments on the website, we are happy to continue the discussion afterwards. Next slide, please. As we said, it's a very full programme and the speakers are slightly different in some cases from the ones that were in the publicity. Just running through these very quickly, we have Sophie John from ONS, and then we have speakers from a Department of Health and Social Care, Sophie Bridonneau, and she is supported, I think it's a three-hander with Sara Haylock and Isobel Flannelly. And then a late entrant, we're very pleased that the ONS Public Service Productivity team is going to present the work they'll be doing on adult social care. So that is Sara and Richard from that team. After that, we move on to NHS Digital. Ojoyi presenting an overview of the range of sources and reports that are available for adult social care. We were going to have a speaker from CQC, David Gledhill. Unfortunately, can't make the date, but if you have any comments, you've seen that in the publicity and you wanted to specifically offer comments to CQC, please still put them in the chat and we'll pass them on to David and we'll try and pick up with him afterwards. We then move on to the speakers from Scotland. Elaine Strange from PHS is not able to make it, but I think she's sent some slides to David and to Jack. So David Cruickshank and Jack Lewis from Scottish Government will then be speaking. I think they've said that it's fairly sort of early days as far as the work they're doing, so they'll be talking more about what they're planning to do rather than the things that they have done. All of those speakers are focusing on adult social care statistics. For the final presentation, it's going to be slightly different. Aideen Maguire from Queen's University Belfast will be talking about the work being done in Northern Ireland for children, that look after children. So there's a slightly different focus to the final presentation. So obviously a lot to get through, and I think that that's probably therefore enough from me, because what you want to do is hear from these speakers. So I will say next slide, please, and hand over to the first speaker, which is Sophie John.
Thank you very much, and good afternoon, everybody. Thank you very much for having me today. So, as Una said, I'm Sophie John, and I lead the social care analysis team at ONS. And the aim of my presentation today is to briefly talk you through some of the work that we're conducting in response to the Office for Statistics Regulation review of adult social care. So, moving on to the first slide, please. Thank you. So OSR published a summary report outlining a need for improved leadership, collaboration and accessibility of official social care statistics. The report also highlighted issues with the comparability of adult social care across the 4 nations and the gaps that there are around evidence. So, for instance, one of those things that we know a little bit less about is the volume and value of privately funded provision of adult social care, or the burden placed on unpaid carers. And this report informed the creation of a work programme for the adult social care team at ONS. Next slide, please, Camille. Thank you. So this is an overview of some of the data that we have available, and includes a mix of census data, survey data and administrative data sources. We have something in our area of ONS called the Public Health Data Asset, which contains linked 2011 census data, and we will be adding the 2021 census data in as well. And that's linked to death registration data, hospital episode statistics, and some GP data as well, which we can use for COVID-related purposes. So working across the UK, so some of the work that we've been doing to improve coherence can be split into 3 main phases. So first, we have been working through where to access and find adult social care data and trying to bring this together to improve data access. The second phase has involved thinking about whether we can compare definitions and data across the 4 nations, outlining similarities where possible. And then finally, once we've kind of built this understanding of the similarities and differences in data, we have a base upon which we can work towards coherence. So the OSR, along with other recommendations, highlighted the need for adult social care statistics to be more accessible. In response to this, ONS has been taking steps to improve statistical coherence around adult social care, and we've created an interactive search tool. So this tool compiles official statistics relating to adult social care across the 4 nations into one location for ease for users. And with this tool, users can search relevant databases that contain data or publications relating to adult social care. So these can be data sets that specifically collect adult social care data, or they can be data sets which contain care-related variables. So for instance, the England and Wales 2011 census features, as it contains a measure of unpaid care. And yes, I will add a link to the tool within the chat after this presentation. So the other issue as well is obviously comparing data across the 4 nations. So we've expanded this landscape recently to include a 4 nations matrix outlining where certain definitions and data can and cannot be compared. And the matrix covers a variety of different care topics that users most frequently request. So for instance, we've got information in here relating to COVID-19. And just to mention, we worked on this in collaboration with Welsh Government, Scottish Government, Department of Health, and Northern Ireland as well. So in response to the COVID-19 pandemic, we have produced outputs analysing deaths of care residents in England and Wales. And we also now publish weekly death registration figures, and that includes total deaths to care residents, deaths involving COVID-19, deaths involving influenza and pneumonia, and then we've also got regional breakdowns within that as well. In 2019, so we published a new annual Deaths in the Care Sector report, which we updated with 2020 data, and we'll be updating later this year to include 2021 data. And this publication covers aspects such as age standardised mortality rates, so comparisons can be made across different geographies. We've got information around leading causes of death in care home residents, and then also year, country, regional and local authority breakdowns. With the 2021 census data as well, we can also think about linking that data on to look at protected characteristics that are not available on the death certificate. So for instance, things like ethnicity. And we're currently working closely with OSR towards badging this as a national statistic. So if anybody wants to have a look at that release and has any feedback that can help towards that badging, that would be great. Another thing we're thinking about doing is whether we can produce estimates on UK deaths in care residents. So I presented last year to the chief statisticians across the 4 nations, and this was one of the outcomes of that meeting. So currently working quite closely with Welsh Government, NISRA and NRS as well to think about whether we can do this based on how well our definitions of a care home align. We have in the past produced life expectancy estimates as well, using the 2011 census data. So that's life expectancy of care home residents. We will update this with the 2021 data. And we're also thinking about whether we can produce life expectancy estimates for unpaid carers as well within that. And that includes kind of age and sex breakdowns, comparisons of life expectancy who are not in care or not providing unpaid care of the same age groups. And we also include age-specific mortality rates there to kind of support with explaining disparity in life expectancy between the different groups that we're comparing. Next slide, please. Thank you. So we are the topic leads for the unpaid care question on census, the England and Wales census. And we've got a number of different census analysis plans around unpaid care, which we published as part of the consultation we did last year. Our plans are to use linked data and longitudinal analysis to answer questions about unpaid carers and thinking about their mental health, general health, disability status, social mobility, and also transitions across the health and social care system. So we want to look at protected characteristics, I'm struggling with that today, across a range of different geographies from national to local level. With reference to the relationship to deprivation and also time trends as well, to assess any presence of inequalities in the provision of unpaid care. And we'll also look at under-researched groups such as young carers. Next slide, please. So there's currently a lot of information out there regarding the social care workforce. However, what we found is when we look at these data, estimates can be contradictory depending on the definition of workforce is used. So we're doing an initial piece of work to look at if there is a best way to harmonise social care workforce and whether it's possible to come up with a harmonised definition. And if anybody has expertise in this area, please do get in touch, because we want to kind of work in collaboration with other people and get as much input as possible into what we should be defining as a social care workforce. So currently, we've just been trying to understand how different data collections define social care workforce, but also understand the best data sources. We've got a number of business surveys within ONS, so we want to look at whether they can be used to support any existing data, so such as thinking about whether we can track where social care workforce may be moved to and from as well. So there's some of the things that we're thinking of doing around that topic. So self-funders, so we're currently working on a new publication which will be released on the 30th of this month, which estimates the number of people who self-fund their care in England. So we did this last year as well, so this will be an update to that release, and we use the Care Quality Commission's provider information return data to create these estimates. So the first part of the project is what we're currently doing, but we have a second aim to look in a little bit more detail into who exactly are self-funders. Can we look at the characteristics of these? Because this is what we can't currently get from the data that we're currently working with. So that's kind of the second phase of this project. And to note as well, so I mentioned this currently only covers England, but we're really interested in working with other nations to try and expand this piece of work. So again, if anyone has any knowledge of any information collected around people self-funding care in the other nations, please get in touch. Moving on then to care pathways. So this is the final piece of work that I'm going to talk about. And we haven't kind of started this yet, but we want to explore whether we can track an individual's trajectory through the care system across their lifespan. So the aim is to understand what are the socio-demographic and geographical patterns that impact the use of health and care services. So thinking about people's age, their health, disability status, marital status, and all of those things listed there, and how they can impact somebody potentially moving into and out of care. And we aim to use the census data to try and track people across different time points. So that's everything from me. I won't go through this slide because I believe I only had 10 minutes to talk and I might have gone slightly over. But overall, these are all of the different things that we've been doing in response to the OSR report. And I know they're currently working on updating their adult social care recommendations. So that will help kind of guide our work programme going forward as well over the upcoming years. That's everything from me. Thank you.
Thank you very much, Sophie. Just before I hand over to the next speaker, which obviously is Sophie and her colleagues from Department of Health, I just want to ask Hira, Manira is not able to get in, so could you resend her the link if that's possible, please? Because she's not been able to get on, and then when she comes on, she needs to get speaker rights. So that's Manira Ahmed. And also, personally, I can't see the chat function, so I'm hoping other people can. I don't know whether there's something about my system. So whether or not Adam or someone could just check that the chat function is working. Assuming that that's all sorted out, can I now hand over to the next speakers, which is obviously Sophie with her colleagues Sara and Isobel from Department of Health and Social Care. Thank you.
Thank you. Can I just check that everybody can hear me properly? I was having an issue with the mute. Cool.
I can hear you, yes, yeah.
Thank you. So my name is Sophie Bridonneau, and I work in the Adult Social Care Data and Analysis team at DHSC. And for this presentation, so I'll be joined by my colleagues Sara and Bella. And this presentation is going to be about the future of adult social care data and the work that we're currently doing in the department to improve this data. So can we move to the next slide, please? Thanks. So what does the current adult social care data landscape look like? So to understand this landscape, we've recently done some work to draw up a picture of regular adult social care collections and data flows. So as you can see from this image, it's a complicated picture where a lot of different actors and entities and organizations come into play in a single data flow. So this image is just to illustrate the numerous and complex data flows, but I'm not expecting anybody to be able to read the detail of it. But it's basically just showing the kind of data flow from the subject of the data all the way to the organization that holds that info. Next slide, please. So as you saw, there is a lot of data collected, but there's also a lot of limitations to these collections. So some of this data is duplicated, meaning that it's been collected several times. It's burdensome, especially for providers to go through all these different systems to provide data. It's not timely enough. Many of these collections are annual, for example, meaning that the information is often not up to date, which stops us from kind of identifying problems and responding in real time. It's also not shared in the most efficient way and widely enough. And there is kind of little standardization of the data, as Sophie mentioned in her presentation. So as opposed to the kind of health policy area, there isn't one national system like the NHS. In this case, there's a lot of bodies that collect that information and it's not standardized across the collections. And then finally, it doesn't meet all the data needs, which was mentioned in the previous presentation as well. So COVID was an opportunity to kind of highlight some of those gaps and the need for better and more timely data. And it was also a kind of a success story, really, because there was an agreement within the sector to kind of concentrate on a centralized collection, to only ask data once from providers and share that information appropriately across the sector. So capacity, this tool was Capacity Tracker, and it was a way to get timely and relevant data from providers for us to be able to monitor the situation and react. It's important to note here that Capacity Tracker was set up very quickly to meet urgent needs during the pandemic, and it's far from perfect. There are a lot of limitations to the system, but it's basically to show that a streamlined data collection is possible. And now we kind of need to build on that momentum. Next slide, please. So over the past year, there's been a lot of work going on in the department to set out a new data strategy and to improve the data in the adult social care sector. I've included a few links in this slide to various documents setting out that strategy, which you could look at in your own time. But in short, this is to kind of introduce these two big pieces of work that are going on at the moment in the department, which are the developing the client level data collection, which Bella is going to give you an overview about, and developing a provider level data collection, which Sara will talk to you about as well. So I'm now going to pass on to Bella for the next slide.
Thank you, Sophie. So yeah, the client level data DHSC project, also known as CLD, was set up as an extension of the Northwest pilot trials, building on the success of working to a standardized social care data specification. The expansion of the project to all local authorities emerged from local initiatives with the aim to collect good quality and timely client level data. Currently, the existing collection consists of an aggregated short and long-term return that occurs once a year, also known as the SALT return. CLD aims to replace this return and increase data flows back to authorities more regularly. The project aims to establish a system that enables local areas to opt in and obtain linked individual health and social care data. The collection will allow frequent monitoring of social care, comparison of local and national flows, and existing outcome metrics using a standard specification. Currently, the project is being extended to cover as many local areas that wish to take part, with the overall goal of the majority of local authorities flowing data by the end of the year. CLD collects the main events and interventions in an adult's journey through the care system when they approach their local authority for funding assessments. An individual event experienced by a person can range, but they are mainly characterised into requests, usually for care, an assessment of needs or financial status, a change in service type such as home or residential care, and lastly reviews to assess outcomes. Each row of the database will represent a person's care event alongside their personal details, which will allow the whole care journey to be accessed for that individual. Records are anonymised but can be linked to a client's health data, allowing a more holistic view of the system to be achieved. I'm going to pass over to Sara now for her description of provider data.
Thanks, Bella. I'm just going to give a quick overview of the provider level data project. So as Sophie mentioned, under the current system, providers complete multiple data returns, often with overlaps. The same data is collected more than once, and this is often due to a lack of sharing across the system. So, for example, care providers are asked to supply data around the occupancy and capacity of their services. As you can see from the diagram, although various organisations request this information, the data items are slightly different. Often LAs are interested in the number of beds available for LA-funded individuals. The NHS and DHSC have similar items around total and spare beds, whereas CQC collect data around the number of people receiving care within a service. Data is also often submitted via different software systems, and this is all hugely burdensome for providers. Over the course of the pandemic, Capacity Tracker has helped to capture the data needed, but we're aware that this is focused on national government data needs, and we want to develop a future system to be more inclusive of others and ensure it's consistent and standardised. Next slide, please. Thanks. So where do we hope to get to? We want to co-develop a minimum data set for a longer-term, stable data collection, which makes best use of existing information and reduces the burden currently placed on providers. And just to flag, by minimum data set, we don't mean a single data collection. It's just the minimum amount of information required to meet key needs of care providers and those who capture data from care providers. We believe this will lead to a more streamlined system where providers only have to capture information once, data collections that complement each other, improved sharing of information where all those who require access or require information can access this, and where possible, fill existing information gaps to improve the sector intelligence. This is an ambitious project, and we are currently in the early stages of our first round of engagement to identify what data should be included within the minimum data set, who should have access to this, and how data should be standardised. Next slide, please. So just to give a quick insight into our first round of engagement, I've outlined a few quotes from the workshops with care providers. We ask care providers what data they collect for themselves and for others and what their data needs are. Benchmarking, demand planning and staffing information were highlighted as valuable information. And care providers also raised the importance of co-designing metrics and improving the transparency of data collections, ensuring data is accessible with clear guidance. Existing data caps included unmet needs and unpaid carers, along with the suggestion of providers having equal GDPR status to other stakeholders within the sector. We'll be hosting these workshops with all stakeholder groups to gather as much insight and input as possible. So next slide, please. And things back to Sophie.
Thanks. Yeah, this is just a bit of a conclusion. So this was a bit of an overview of the work and the thinking that's currently underway in DHSC, and all these projects will support the build of a data ecosystem that is simpler, more accessible, and hopefully non-burdensome. So yeah, I'll hand over back to Deana, as this is the end of our presentation. Thank you.
Thank you very much, all three. That was very, very interesting. But obviously, lots of things to look at later on. Just reminding people that any comments or thoughts, please put them in the chat so that we can capture them in the Q&A later on. I'd now like to hand over to the next speakers, which, as I mentioned, is from the sort of productivity team. Sarah and Richard, would you like to take over now, please?
Yes, so thank you, and thank you for the opportunity to present our work in this meeting. We are from Public Service Productivity at ONS. In Public Services team, we are analyzing the productivity of all the public service areas in the UK, and indeed adult social care is one of the main areas that we are taking in consideration in our statistic. During this presentation, Richard will go through the methods that we use, our approach. It will give us some last results that we have recently published, and also it will show some challenges for the future, and we will look forward to the discussion later on this one as well. Richard, over to you.
Cool. Thank you. Could I just check, do I need to request control, or will the slides be advanced for me? I can see already it's clicking forward. Great. So why does productivity matter? So you can see on there's a famous quote there from Paul Krugman, and it's one of the most cited about productivity. Now, he's highlighted the importance of the concept of productivity for the well-being of the entire society. Now, productivity isn't about working harder. It's actually about embracing new ideas and technologies to deliver more output. So I'm going to give a very high-level overview of productivity, and the main slide at the end, when we talk about the COVID challenges, it'll help to understand why those challenges are affecting us in the way. So output, inputs and quality adjustment are the main concepts that we use to define public service productivity. In the next slides, we'll give a definition of outputs, inputs and the quality adjustment. What you can see in this slide is that public service productivity is estimated by comparing the growth in the total quantity of output provided with the growth in the total quantity of inputs used. So if output grows by more than the input growth, productivity increases. And what it means is we're getting more output being produced for each unit of input. And conversely, if inputs growth exceeds the growth of output, then productivity will fall, and it indicates that less output is being produced for each unit of input. Now, in public service productivity, it's also very important for us to define the quality of service delivered, and we use some specific measures of quality to achieve this. And because our statistics are measured over time, you can see another variable there, the deflators. We use the deflator to take into account the changes in the value that comes from the changes in prices. So what inputs do we use? So the adult social care inputs, it consists of two main components, and it's all public expenditure on adult social care services. So we're not looking at the private sector at all. And the other element is the deflators for measuring the change in the costs of inputs. Now, of those input components, the cost of purchasing care from the independent sector is the largest. Now, local authorities, labour, intermediate consumption of goods and services and capital is also included. So how do we measure output? So where we can, we do like to measure output using a direct measure of activity. And in the case of adult social care, we use data for the residential and nursing activities. And this is the number of weeks of care delivered. And then we calculate the unit costs, and then we can weight the activity by the unit costs using a cost-weighted activity approach. Where data doesn't exist, what we have to do is calculate output on an output equals inputs basis, and we use the expenditure data for that. Now, the quality adjustment. The Atkinson review in 2005, it had this following statement. So normal market goods have a price, which when it increases would reflect an improvement in quality. Public services have no market price. Therefore, we cannot use prices to assess these changes. So we need to look at other ways, and we're looking at the change in quality received of those services. Now, we apply the quality adjustment to output, and it's to show the impact on desired outcomes from the service provided, and also how the output provided in this service area affects the outcome of the service. So in public service productivity, we published 2 ad hoc articles on adult social care. One covers the UK, and this is published on a calendar year basis, and it's part of our public service productivity article. Now, the other only covers England, and it's published on a financial year basis as a standalone article. And our next publication for the England data is on the 14th of July. So I'm going to share some of the productivity estimates with financial year 2019-20. A little bit of data on the slide, not too much, but I'll explain why it's there and the relevance that it'll have. So, as you can see from the first 2 bullet points on the slide, the non-quality adjusted output, it increased at an increase of 0.7%, and that's actually lower than the inputs that increased by 1.1%. This actually meant that the non-quality productivity actually decreased by 0.3%. Now, as mentioned earlier, the quality adjustment, and that is the measured increase or decrease in the quality of service, it's applied to the output. Now, in 2019-20, the quality adjustment was plus 1.3%, and this meant that quality adjusted productivity increased by 1%. Now, the key takeaway message from this slide is that the quality adjustment can really make a substantial difference to our headline productivity figure. Now, we're still in discussion with NHS Digital and colleagues from the ONS for the best solution for our statistics and the best way to meet the needs of the stakeholders. So when we look at this development work, we haven't made any firm decisions. So any thoughts, comments, ideas will be really greatly appreciated. And the limited data that is on the next slide, it's all publicly available. So what challenges have we had with the 2020-21 collection? So, no surprise, it's pretty much due to the COVID-19 pandemic, and it's affected the inputs, output, and the quality adjustment. Now, when we're looking at the inputs, care providers and local authorities, their focus was on delivering safe, accessible care to those in receipt of adult social care. COVID-19 grants were included in their usual expenditure lines, and this was due to a lack of time to update data collection tools. It's not just as simple for them as recording the expenditure, because most of this expenditure needs to be coded to a primary support reason. That's the reason why they're getting their care at the time that that care is delivered. Now, with the COVID-19 grants, they were mostly included in an area which is commission and service delivery expenditure, which is the management of the service. And it rose from 1.1 billion in 2019-20 to 2.3 billion in 2020-21. The total spend for that year, for the 2021 year, was 18.3 billion. So it gives you an idea. That's a large proportion of that money. Now, the commission and service delivery accounted for around about 1 billion of the COVID-19 grants. So even if we could identify that and where it's impacting, there's still approximately 0.3 billion pounds accounted across the other expenditure lines in the adult social care finance report. Now, activity, but then looking at the output, we've got the activity data, which is available for both residential and nursing settings. We do have activity data for short-term care to maximise independence, but we've had issues with this data prior to the pandemic, so we only use the residential and nursing activity. Now, the normal activity is based on weeks of care, and this care, it's that care that's been delivered to publicly funded residents. So during the pandemic, there were hospital discharges and to care homes. They were paid for by the NHS, but some of this activity may have been included. We've got a large range of independent providers, and when they're submitting the data back, it can be difficult to get everything accurate. Now, the COVID-19 screening, the time and cost of changing personal protective equipment between residents, and the extra time taken to care for residents, this was funded for by the COVID grants. It was public money, and it covered care that was given both to publicly and privately funded residents. Now, we don't capture activity data for private residents, so there'll be activity data that's not in there that represents the money that was spent in those grants. And something else with the activity data, some local authorities, they booked and paid for empty beds. Now, this was to ensure the financial resilience of the care sector. And some of this may also appear in the activity data. The reason why that decision was made to do that as well, they realised that if a care home closed during the pandemic, it would be very, very unlikely that those residents could have been rehoused somewhere else. Now, the quality adjustment, that's also been impacted, not in the way you'd think, in the sense that it's all negative news. During that first year of the pandemic, so the financial year 2020-21, the Personal Social Services Adult Social Care Survey was made voluntary, and only 18 of the 151 local authorities submit responses. And to give you an idea of the impact, in 2019-20, we're just over 53,000 fully complete surveys, and in 2020-21, it dropped to just over 5,000. So again, we're still trying to work out if we can use that data within our figures. And thanks for listening. You can see mine and Sara's email addresses on there. So if you don't raise questions at the end, you can still contact us directly. Thank you.
Thank you very much, Richard and Sara. That was, you mentioned obviously your discussions with NHS Digital and looking at the data availability and potential gaps or whatever. So that very much nicely leads into our next presentation, which is from Ojoyi in NHS Digital, who'll be talking about the suite of data collections and publications, and also possibly looking at gaps and developments. So over to you, Ojoyi.
Thank you very much, Deana. Hello, everybody. My name is Ojoyi, and like she has said already, I'll be presenting on the suite of data collections and publications we have in NHS Digital. Could we go over to the next slide, please? So this presentation is going to cover the suite of our publications, our annual publication cycle, the gaps in data and insights, which almost every speaker has already touched on, and then also the new developments we have in the horizon. Next slide, please. So on this slide, we have divided all our publications and collections into 5 different themes: activity, surveys, finance, performance indicators, and the registers. So when we talk about activities, all kind of care that's all kind of activities that are, classed under adult social care. So under that, we have the SALT, which DHSC has also spoken about. Here we have the short and long-term support that are given. Then we have the safeguarding adults, which is the SAC collection that we do. We have the deprivation of liberty and safeguards, and also the guardianship under the Mental Health Act. In terms of surveys, we do carry out surveys to understand the quality of care that's being given, how the users feel about the survey, and how the carers also feel about the care that they are given, if they all feel good about it. So we have the adult social care survey, the survey of adult carers, and also the health survey for England. Then under the finance bracket, like we could imagine, is everything regarding the whole financing of the adult social care. So we have the adult social care finance return, and also the deferred payment agreement. For the performance indicators, we can tell that this ASCOF, which is the Adult Social Care Outcomes Frameworks, feeds from the survey and also the finance as well. It's been able to measure the outcomes of care that is given under certain indicators that have been stated. Then for the registered, we have the Register of Blind and Partially Sighted, which is the only register we have for now. So most of our publications are annual. I think Sophie has mentioned earlier that it may not necessarily be timely, but that's what it currently is at the moment. We also have one publication, which is a survey of adult carers, which is every other year, and then the guardianship under the Mental Health Act and the Register for Blind is every 3 years. On this slide, we also talk about our key stakeholders. It's not a full list, of course, so these are just the main 3 that we have. The Department for Health and Social Care, Local Government Association, and also the Association of Directors of Adult Social Care. Of course, we're aware that we have charities that use our data, the general public, and other people who may not necessarily be on this user persona that we've put on here. Can we go to the next slide, please? So on this slide, we show our annual publication cycle. It usually starts on September every year and ends the next September. So we have a series of publications that we do. They don't all necessarily start off at the same time, but all of them go through this process. So the first step is in September, we have the September letter that is being released. And in this letter, it tells us a lot of information about what's going to be released the coming September, when are the publication windows going to begin, when it's going to start off, and when are the publications tentatively going to be set out. So our first step, like we can see here, is the data gathering. So data gathering and collection. So we, the analysts at NHS Digital, we get the templates ready for the local authorities, then fieldwork can commence. Where local authorities in terms of surveys can start sending out the surveys, collecting it back, collating the numbers, and then sending us the information. We usually have the windows open at a particular time in the year for the different publications. And during the first deadline, they'll be able to send this data to us. So if you click on the next step, so this is once data gets through to us, we do like DQ reports and validation just to ensure that the quality of the data we're receiving is right. So we send these DQ reports back to the local authorities, and some have a look at it and say, oh, I'm going to, make another submission to make sure that the data we're sending in is more representative and reduce the amount of data quality issues that we have. So they're able to do this during the next submission window. Then the next step is data analysis. So when the data is back, we do like an analysis of the data we've gotten, identify the key trends that we find in the data, do any necessary comparison that needs to be done with the previous year, or maybe the England or nearest neighbors, just to try and have a feel and understanding of the data. And then we start putting the publication together. So can we have the next bit, please? And so in the last bit of this window is when we get the publication together, make sure that we are getting our Power BI dashboards launched. We also start the development or commencement for the new cycle. One thing that's really interesting about our annual cycle is we try as much as possible on an ongoing basis, ensure that we're giving continuous support. We're speaking to the different stakeholders to ensure that, the requirements are still the same. it's also very, very important for us to know that we have working groups available where we all go back to the drawing board to ensure that, you know, there's a continuous improvement cycle that's going on alongside the publication as well. Can I have the next slide, please? So in terms of new developments, what do we have going on right now? I mean, aside the fancy things like the CLD that we've spoken about, LPS, we also have the RAP, which is the reproducible analytical pipelines, which we're currently doing on the team. I think it's a government-wide initiative where we're trying to bring the best practices from software development into the world of statistics. It's also something that's being used to bring more transparency with the code that we use. So we're moving from you know, SAS going on to open source languages like Python and R, being able to automate the processes that we are currently done by the analysts to increase that morale and bring also that boost. Also to improve our code, the quality of our code and the efficiency of our processes, so that if one person leaves the team or one person leaves the organization, we still have view or sight of what we are doing. So documentation is something that's very, very key as well. So now using version control is something we're also trying to move to, not just as NHS Digital, but I believe the whole statistical group. So it's something that's really strongly going on within the adult social care team currently. In terms of the outcomes framework, we're reevaluating these indicators that are currently used at the moment to measure the performance of the adult social care outcomes. That's currently ongoing and I think should be ready for some time next year. So based on the review of these indicators, that's going to state if we need to explore new data sources just to make sure that we are getting the right outcomes for adult social care. For the survey discovery, so there's currently a survey discovery that's going on at the moment. In as much as the team is not directly working on this, we're giving that SME support to the team working on this, participating in the interviews, and also reviewing draft reports. The whole purpose of this discovery is to ensure that, you know, we're getting a true representation of what people feel about the care that they're giving and the care that they provide. Also making sure that we're doing it the right way. Is there anyone that's missing? Is there a better way we can, you know, deliver this? So almost like going back to the drawing board to ensure that it's being delivered in the proper manner. Then the last bit is the website reconstruction. So that's something that has been very, very key within adult social care, trying to make sure that the data we're working on and the information we give is accessible. It is in a central place, because prior to now, we've had our data moved over different places on our website, on different websites as well. So bringing everything to a central point so that our users can have access to our data easily. So we have the publications in one space, all our dashboards, all the collection materials and the guidances that are provided for the local authorities, that is all put in one space now. And in terms of Power BI, we're ensuring that we're using best practices to show our data or to visualize our data, to make it easy and interpretable for anyone that comes across it. So the last slide, I believe. So what are the gaps and data, the gaps we have in our data and the insights? The first is the demand for adult social care. This is what limitation I think someone has spoken about earlier. So we're from the local authorities, it's not possible to know 100% the needs that have been unmet. People who are giving informal care, and as someone has mentioned earlier, who the self-funders are and the PAC funders are. So this makes it it gives that gap of not knowing what the true demand is within the local authorities and in England at large. Then in terms of the outcomes for those in receipt of adult social care, so it's quite difficult for us to know the quality of care, and because we just measure long-term care, it's difficult to have a grasp of what, like, people who, you know, give short-term care, how do we get the quality of that? And then the seldom listened to cohort. So those that receive care that do not have the mental capacity to say, oh, I like this care, or I would have preferred if this is done this way. So they don't have the capacity to fill the survey. So we are not able to get a true picture of that. Then secondly, people who currently have the survey written in, I think, 28 different languages, including English. So people who don't fall under that bracket, we're still missing, you know, the outcomes from that. So being able to know how they feel about the care that they get, and also providers of adult social care. So we know that care homes do give care, of course, but how are we able to get that data from them? What kind of care do they give? How much does that cost? That's not something that we have sight of at the moment. Then we're also aware that there are domiciliary care organizations that give care as well, but we don't have full like that data to be able to add on to what we currently do. And of course, charities, you know, charities do give some sort of support financially, or just even, you know, have some care homes or give some sort of form of care. But because we don't have that data, it's very difficult to give a true picture of, you know, what the adult social care space is like. Then the last bit of data and insight gaps is the interface between the health service and adult social care. So there's that break or that divide between the health service and also adult social care, and the inability to see the end-to-end journey of these clients. It's a bit difficult because it's that lack of connectivity at the moment that's happening now. So if we could do that connect or that link to give more insight to the data, we'll be able to feed into more things that are done on the health services, because we have this data that we have now. So hopefully at some point, we'll be able to get linked records and also understand better the pathways of care. I believe this is the last slide. I don't know if anyone has any questions. I'm hoping that they will be in the chat section.
Thank you. Thank you very much, Ojoyi. Yes, please put your questions and comments in the chat. As I mentioned at the beginning, we would have been having a presentation from the Care Quality Commission, but they can't make it. But if you have any specific questions for them, please put that in the chat as well, and we'll pass them on. So we'll now pass over to the colleagues in Scotland about their progress and plans. And this is a two-hander from David from the Social Care Analysis Unit, and Lewis, who's in the data and digital side of things. So over to you, David and Lewis.
Hi there, thanks very much. Yeah, I would say, as you said, Deana, this is very much different from the past presentations. Is really setting out plans and just as introducing ourselves, as it were. So I would say we're slightly behind England in many respects to some of the work we've done. But I'm David Cruickshank. I head up one of the teams within the Social Care Analysis Unit, really responsible for trying to improve the evidence base in relation to, in response to the OSR, both the OSR report, but also to try to monitor or input to and monitor the setting up of the National Care Service here in Scotland. So yeah, I'll go through the slides. Basically, we're going to talk a little bit about the development work we're going to be doing here in Scotland, but also to try and provide a little bit of the context of that work, and to say where we are in our plans and what we're currently planning to do. So if we go to the next slide, that'll be great. Cheers. Yeah, as in England, we had the OSR report back in, I think it was February 2020, which basically stated very similar to the reports that were chatted to earlier by the two Sophies, that basically, despite the high volume of things that are collected within Scotland, the evidence base isn't necessarily very complete or coherent. And in fact, it's actually quite confusing and cluttered in some respects. And it came up with a number of both short-term and longer-term strategic recommendations. In terms of those short to medium-term recommendations, I think it's fair to say that we're only really getting round to them now. The capacity within the team hasn't been great over the last couple of years, and COVID has taken taken much of the resource in that respect. But now that we're starting to upscale the resource, which was actually one of the recommendations in the OSR report, we're starting to make some progress in that. Just to give an idea of the newness of the team, I've been in post for 3 months, and Lewis has been in for 2 months, and we're by no means the newest people in our teams. But as well as the OSR report, I mean, if we can go to the next slide, I mean, this shows that last slide showed the kind of the number of data producers within Scotland, and it's one of our key roles is to try and ensure that we're producing a coherent picture. I guess the standardization of definitions, etc., which have been mentioned in the last presentations, is very much key there. So onto the next slide, I guess, as well as the OSR report, we have the extra considerations of the proposed significant changes put forward by the independent review of adult social care in February 2021, the Feely report, as we know it up here, which is going to bring considerable changes to the way that social care is delivered. And we can't say much about what that's going to look like at the moment, but one of the key recommendations within that report was the setting up of a national care service. So, as I say, that's currently going to be going through Parliament. The bill is due in June this year, but a lot of the work that we have been done within social care analysis unit to date has been around providing evidence to support some of the key decisions that are going to be made there. And in future, there's going to be a bit of monitoring and evaluation. So they're the two main things that the context of a lot of our adult social care work will be done under. If we can move on in the slide, please. Yeah. This is kind of moved across a bit, but yeah, this is just to introduce the team in terms of the social care analysis unit. And until recently, social care was probably a couple of statisticians working on social care within the wider health and social care teams. However, in 2021, last year, we set up a dedicated social care analysis unit, and that now contains, I think it's about 7 statisticians, 3 researchers, a couple of economists, and an operational researcher. So we've hugely increased the capacity around social care analysis. And now, I mean, it's really only been since the beginning of this year that we're at full capacity, so we're starting to make some progress. These are I've highlighted there the main priorities for the team over our current, but probably over the next 12 to 18 months. The top 2 there, the NCS, clearly there's been a lot of evidence required for the bill. But there will also be, as I said before, monitoring and evaluation. The COVID work, thankfully, that's reduced a little bit now, and will hopefully stay that way for the foreseeable future, at least, which will allow us to get onto the bottom 2 headings of developing and communicating data and evidence. It says for policy making there. I think that doesn't really need for policy making. It's just for everyone in terms of the improving evidence. One of the key things there, as I said, is there's a number of agencies in Scotland that are producing statistics. So it's to try and get a coherent plan around what the data collection, what the data needs are, and how we go about collecting it. Because yeah, we collect a lot of data at the moment, but it doesn't really bring a lot of insight. Again, it's similar to what has been said earlier. We need to improve our current publications. We don't actually collect as much as we used to, but again, the OSR report was quite clear that what we are producing needs to improve in its presentation and its commentary. And then I guess the bottom one around developing approaches to the new area of work. This is really, as well as the incoherence is perhaps the wrong word, as well as evidence-based not being particularly coherent, there's a lot of data gaps, and this is where we're going to be focusing our attention over the next 6, 12, 18 months. And part of that will be around capacity building. We want to make sure that we're tapping into academia. We understand that there's an active community out there. We want to ensure we're learning from it. And the idea is to try and get as many people on board, as it were, to try and develop the analytical and evidence-based that we know. Part of that is PHS and DD, where Lewis works, the Digital and Data Division. There's a lot of organisations and areas within Scottish Government who are working in very similar areas. So it's just to ensure that we're all very clear on the roles and responsibilities of each of ours. So again, we're at the very early stages of finalising those, and then in terms of the other people within the team, we have operational researchers and researchers. So it's trying to get whole system modelling. So again, it's trying to probably try and tap into some of the work that's been done down in England around trying to understand the systems. We can go on one slide, please. This was Public Health Scotland were going to be coming along. Unfortunately, they couldn't make it. So I will just read off about a little bit about them. I mean, Public Health Scotland are probably the main data collectors within Scotland. They collect a huge amount of data, and in recent years they've taken over a number of the publications that the Scottish Government used to do. One of the key benefits of this is they can now link the social care data to the health data that they regularly collect within their source data set, and a lot of that's published within their Insights in Social Care publication. But this is just a list of some of the publications and some of the data sources that are available to source. And I think the next slide is to bring in Lewis, just because there's a couple of areas within Scottish Government that are looking at this. So bring in Lewis.
Hi there. Yeah, as David said, I'm in the social care data and digital division. I work in the data team there as the NCS data lead. So yeah, again, as David said, I'm fairly new to the role, and it wouldn't surprise you that the division itself has been established quite recently as well. It was created to give additional capacity support to the implementation of the National Care Service. And at the moment, we're focusing, as well as similarly to David's team, in understanding what the current data and digital landscape is looking like. And as part of that process, we're reviewing the existing collections, identifying gaps and areas of duplication on those existing collections, but also the requests that we are placing on organisations and trying to establish solutions to reduce the burden around these areas and rationalise the data sets themselves. On top of that, we're obviously considering responses to the consultation for the NCS as well. Yeah, you can probably go to the next slide. So this slide is kind of covering what both of our teams are looking at, as well as PHS. So the development of social care data and evidence, again, we're trying to understand the system there and reduce duplication and improve the current data. We're really wanting to develop a coordinated multi-agency approach that's working with the analytical unit in Scottish Government and ourselves, but also more widely with PHS and other organisations within the social care data landscape. And we're looking at the use of social care data and evidence. This covers the regular statistical reporting, potential new statistical reporting, and social care outcomes monitoring. In terms of the National Care Service, again, we're looking, these all kind of like relate to this because we're trying to improve what's here in order to facilitate the transition towards the National Care Service and how that's going to look. So we're going to use that data and evidence to inform what the National Care Service will look like in the future. I think we can move on to the next slide. And I'll hand back to David.
Thank you. Yeah, we've put in this slide because this is one of the few concrete data work programs that we have on with timelines. We know we're going to be looking at the whole social care data landscape, but we're starting with care home data review, and as we speak, we are looking at the landscape around that in terms of who asks for what, when, and see what overlap there are, and to understand the burden on suppliers. We'll then take that by the end of June. The idea is to try and understand the robustness of some of that data, because quite a lot of the data we collect, we think we have data, as was shown during the COVID pandemic. We think we can answer questions, but then when we actually go to answer it, we're not able with the robustness of the data. So it's to try there and look at the data quality and coherence and completeness. We're then going out to stakeholders between June and August to understand data needs, but it'll be on the data users, but also data providers to understand, again, their burden and also the problems with providing some of the data that we're asking. And then towards the end of the year, we're going to try and write up on this and come up with new proposals around how we can meet the needs of care home or the evidential needs around care homes that we need. And then we'll implement them at the beginning of next year, with the idea being that things like the care home census, which has just gone out for this year, may look slightly different next year. There may be different ways of collecting some of that information. But yeah, we just thought I'd put that one in just for it's one of the few ones that we're up and running on at the moment. And the next slide, I think, is just our contact information in case anyone has any queries around any of that, or would like to get involved in any of the work that we're doing. Again, as I say, we are at the start of a lot of this work, so it'd be great to hear from people. Don't know if that's well over 10 minutes. Maybe that's where Deana's coming in. Sorry.
That's okay. Thank you very much, David and Lewis, because obviously you were handling two different sides of the work. So that's very interesting to see, the direction you're going in. It almost seems like we need to have a rerun of this in sort of 6 months' time to see how things are going, and pick up on some of the questions that have been raised. So thank you very much. As I said at the beginning, we're the last presentation is moving on to something slightly different. It's still in social care, but focusing more on children, looked after children. And we have Aideen Maguire from Queen's University Belfast who'll be speaking to us about that. Just checking in the technical. Are we now on Aideen's screen share, or I think we just need a. Yes, that's right. So we've got a slight technical. So I think we're now with Aideen sharing her slides. So over to you, Aideen. Are we okay there?
Sorry, thanks, Deana. Can you hear me now?
Yeah, I can hear you now. Yes.
Apologies. Always technical difficulties. Yeah, thanks everyone for inviting me to talk today. And like Deana said, my presentation will be a slightly different slant, but hopefully there'll be maybe some crossover messages. I'm a lecturer in psychiatric epidemiology in the Centre for Public Health at Queen's University in Belfast, and I work within the Administrative Data Research Centre Northern Ireland, which is part of the wider UK-wide ADR network. And I'm going to talk a little bit today about what we can learn from Northern Ireland health and social care data, and sort of what important lessons I've learned. The research I'm particularly interested in is exploring mental ill health in those known to social services or previously known to social services in Northern Ireland, so this includes children. So although the major focus for you guys is adult social care, I'm going to be talking about child social care. And I think what's interesting is that within the ADR Northern Ireland, we're working towards improving data quality, and we can see that that's happening across many platforms and networks across the UK. And I think it's really important that we do talk a little bit more so people aren't duplicating work. But just a bit of context, number of children in care is rising in Northern Ireland. It's rising across the UK. And we know that these children have increased mental health needs, increased risk of early mortality, etc. And although we know all of this, we know very little about why this happens. So I'm going to talk very briefly about the research question and then a bit more in detail about the data. But let's say, for example, we want to explore a child's timeline. We know that they're born at a particular time, they become known to social services, they maybe enter care later, and they maybe turn 18 and leave care. Much of the research to date and the data to date has looked at this time period, so when a child is in care, and this is the easiest one to explore, and we know that children here have an increased risk of poor mental health. But we know very little about what goes on before, about their adverse childhood experiences before they enter care, about the care experience itself and how disrupted that is. And also what happens in that interim period where they're known to social services and there's maybe investigations ongoing. They're referred a couple of times before they actually are taken out of their home and placed in out-of-home care. But we have administrative data that can explore that. So we have information from birth registries, from GP registration, on when a child is born. We know adverse childhood experiences from area level information. Mental health can be measured by hospital data, prescription medication data. We've got social services data that let us know when a child becomes known to social services, when they enter care, when they die. And that's exactly the research that I've carried out. So within Northern Ireland, we have an integrated health and social care system, which means that all of the social services data is held centrally by the Business Services Organisation. And it contains health and care number, identified with a little red dot here, which means that it can be easily linked to other health data. So for this particular project, this health and social services data dates back to, it was first made electronic or backdated electronically to 1985. So we were looking at 30 years worth of social services data here linked to GP registration data, hospital data, prescription medication data, and death records. Hospital data here just relates to admission and discharge data. And I think the main aim here sort of was to make use or see what use we can be made of administrative data sources as opposed to the usual sort of census data or survey data where you've got information that's very staggered across different time points. For example, the census, you're looking at information 10 years apart, whereas within, for example, primary care GP registration data here, we can get real-time address changes of when a person moves into changes address, or for adult social care it might be of interest because we can see when a person moves into a care home. So like I said, all of this data is held centrally within the Business Services Organisation in Northern Ireland, which is the Northern Irish equivalent of the Business Services Authority. And within that we have a trusted research environment, a TRE called the Honest Broker Service. And most of the data is within their own data warehouse, except for there's emergency department data relating to presentations for self-harm and suicide ideation, which is held by the Public Health Agency Northern Ireland, which we were able to link in but just required some additional data access agreements. So I'm sure you're all aware of how TREs work, so I won't go into this, linking the data, anonymising it, making it available in a safe setting. And just to go over some of the lessons I've learned from this project, the first lesson relates to the data itself. So the social services data in Northern Ireland, kind of like the CLD data, I suppose, from DHSC that Sophie and her colleagues are talking about, is complex. It's not a nice, easy data set. It's not one data set. In fact, it's a collection of modules where you've got children in care, history module, children in need referrals, child protection investigations, information on physical learning and mental disabilities. There's also within this the adult social care statistics, or modules, but I was just looking in particular at those that related to child social care, with the idea of taking as much information as possible from the data to gain a picture of a child's journey through care. There's a lot more modules, a lot more information within the data set, but one of the challenges of this project was determining how much data was needed to be extracted so that you didn't lose the context of the individual within the care journey, but that you still kept some level of detail. And one of the first things that we discovered was that health and care number is not present in every record. So the health and care number denoted here by a little red dot is what we need to link social care data to other health data sets. And like I said, it wasn't present for every record. For example, in the children in care history module, 21% of rows were missing a valid health and care number, 11% in children in need, 17% in child protection were missing valid health and care numbers. Now this doesn't necessarily equate to individuals. It's 20% of rows. So a row equates to a particular event. So if an individual a child is in and out of care maybe 10 times in their adolescence, then 8 times there's a health and care number present, but 2 times the health and care number is missing. So although you're identifying that child was in care, you're maybe missing some of the care journey or some of their experiences. And this is a real problem, which left a sort of question mark over the whole data set. And it's something that needs to be addressed. When we compare it to something like hospital data that's been used extensively for decades, we've got nice clean ICD codes, admission, discharge dates, health and care number coverage is 100%. This data is audited, it's checked, there's finance checks, it's audited by clinicians, so we know that it's well established and it's good quality data, and I think we're not at that point with social care data yet. In terms of the representativeness of the data that did have a health and care number, it looked pretty good. You can look at that in your own time. So within my project, we explored the data from 1985 to 2015 and found that the first 10 years of data were quite poor. So most of the data linkages just occurred from 1985 onwards, looking at GP data, death data, and all of these mental health outcomes, which allowed us to examine a nice cross-sectional look at the mental health status of children in care or known to social services, and then a nice bit of longitudinal analysis too. The lesson number 2 that I learned, I think, from the data was that there are lots of children known to social services, and I suspect this is the same when we look across adults known to social services as well. Although less than 1% of the population are looked after children, over 1 in 6 children in Northern Ireland were previously known or currently known to social services. So that means perhaps they were referred to social services but deemed not in need. They were referred to social services and identified as having been a child in need but remaining in their own home. And it was only the very small percentage that are actually removed from their home and placed in care. So I think this shed an awful lot of light on the workload within social services and understanding the exposure of individuals to social services, not necessarily just the extreme either being in care or being in residential care. As interaction with social services increased, so too did poor mental health. We see 10 times the rate of antidepressant prescribing in children in care, 50 times the rate of antipsychotic prescribing, and 25 times the rate of self-harm compared to those never known to social services. We'll look at who's most at risk, and we're able to look at factors, looking at gender differences, referral age, number of episodes, duration in care, type of care, and all this wealth of information that we weren't able to look at in such detail before. Using administrative data, we're able to do this quite easily and look at things like, is there a significant difference in mental health outcomes depending on whether a child is in foster care or kinship care, because there's been a real push in children's social services for kinship care placements. And what we've found within the research is that it doesn't seem to have an effect on their mental health outcomes, at least. And then also was able to explore mortality after leaving care. I'm not going to go into too much detail into this, but I think what's most important in these slides is that through data linkage, we're able to identify for the first time this group of individuals, and that's those that are identified as not in need. So it's children that are referred to social services, they have an investigation carried out on them, and it's deemed that they don't require any support. And these guys haven't appeared, they don't appear in surveys, they haven't appeared in any national statistics, because we just look at those who are identified as a child in need or those who are looked after. And this may be interesting in adult social care as well, where we look at individuals that are referred and potentially deemed to not meet requirements to get support. And we can see that mortality risk increases with interaction with social services, and these individuals that are deemed not in need are also at an increased risk of poor mortality outcomes. So in terms of what have we learned, the biggest lesson I think is about the data. I worked very closely on this project with the head of Looked After Children and Adoption Policy at the time. She's recently left in the Department of Health in Northern Ireland, and she was stating that as a department they know that the right data doesn't exist for further development in that area. And I think lesson number one is work closely with stakeholders in the department, because the only individuals that can enact change are those that are policymakers. In terms of the data, just revisiting data quality a little bit, I mentioned briefly how hospital data is kind of the gold standard in our research area anyway, in that we know that it's uniformly high quality data. And it is mostly because it's driven by quality checks. In terms of social services data, it's variable. There's no standardization in how it's collected. There are missing personal identifiers, like I mentioned, like health and care number. Because health and care number is missing for some rows, that means that we miss some episodes or interactions with social services, which means that the last interaction date we have for an individual may not actually be their last interaction date, because there may be additional rows of information that we weren't able to link because it didn't have health and care number. So we can't be 100% sure when an individual leaves care. For children in particular, there's no family identifiers. And I think what COVID showed us was that within the data already, we cannot really tell how many people are in either residential homes for children and young people or care homes for older people. Another issue within Northern Ireland, and I'm not sure if it's the case in Scotland or across England and Wales, is the way data is recorded. Currently, or historically, Northern Ireland used SOSCare as the package or the platform to record social services data. But from 2015 onwards, it's been moving towards a new system of recording called PARIS, which leads to lots of problems. PARIS isn't centralised in the data warehouse like SOSCare is. We can't access that data as researchers. It's not yet used in all health trusts, although it was meant to be rolled out in 2015. There's 5 health trusts in Northern Ireland. Some of them are still using PARIS, and some of them are using a mixture of PARIS and SOSCare. And we don't know if the variables will be comparable over time and what the health and care number coverage is like in that. So although administrative data is fantastic, in terms of streamlining the data and ensuring that there's a clear movement between systems, we don't know how that's going to look. And I think moving forward, it needs to be a priority. We're seeing a massive increase in the use of administrative data for research, and also post-COVID, and with our recording of COVID cases and deaths and even vaccination records. I think the government now is also seeing the benefit of administrative data, but it's important to know your data. And I think one of the questions I saw popping up earlier was about sort of local authority data coming in, and does anybody have any experience in using it? And I think it's very important to work with the data providers. And we worked very closely with social workers and individuals in the front line to see what do they mean by the data that they're imputing. And I think it's really important that you know your data and aren't just taking it at face value. And it's important for us to be advocates for data quality improvement. And just some acknowledgements there. It is a little bit off topic, I'm sorry, but hopefully it's some interest to some of you in the group. Thanks.
Oh, thanks very much, Aideen. I mean, obviously, there are many similarities in the issues that need to be tackled. So, I think it is very, very relevant. And obviously, there's the linkage between what happens in the childhood and adolescence and moving on to adult social care. So there's also very much common issues. So that was actually very helpful to have that other perspective on it. So now we move into the final stage, which is the Q&A. So we're still sharing. I think we're not sharing this. We need to move on to the panel session. My colleague Munir Ahmed has been keeping an eye on the chat as it's been coming in, trying to pull that together. So what we will do is, if all the speakers would actually put their make themselves visible so we can actually see them, and then Munira will start posing questions to them either individually or as a group. So if the speakers could sort of come online, so we've actually got the panel, and then Munira can sort of take it from there. I think most of the participants have stuck with us right to the end. It's quite a long session, this one, so well done for that. So we have another half hour for the Q&A session. So over to you, Munira, to coordinate it.
Oh, thank you so much, Deana. I always get the best job of the day, which is really understanding a little bit more about what our speakers have been sharing with us. So as the speakers all come online, firstly, a massive thank you to everybody. It's been really, really informative, and I can see in the background, you know, your teams collectively be answering a lot of the questions as well. But I'm also mindful some of the participants that will be joining today will not have seen the chat or have had access to the chat, so I'll apologise in advance if I'm going to repeat some of the questions that you've already answered. It's truly because everybody gets a chance to respond, and a massive shout out to your teams in the background that haven't spoke but have been answering the questions as well. So just a shout out to them. So before I start with all the questions, I guess I wanted to kickstart on one or two things that I heard everybody talk about. And this was about having a whole systems multi-agency approach and the importance of bringing together the different service providers, organisations, partners, stakeholders in the systems. And Ojoyi, you can start to talk about it, thinking about from a digital and data perspective. But my question to all of you collectively before I come individually to the questions that have been posed as well, and this picks up some of the things others have been talking about, is the importance of impact being made by the collection of these insights. So can you share from your perspective, and knowing that you've got an active audience amongst all the participants, what has your learning been around a multi-agency approach, and is there any kind of positives and negatives that we should stay away from? And Ojoyi, not to put you on the spot, but can I maybe get you to kickstart by sharing some of your learnings? It could be just one or two things, you know, that'd be great. Ojoyi, over to you.
So I'm assuming that's me. If you could go over the question again and just help me ask
Yes. So
please.
yeah, just some of your learnings from using a multi-agency approach and having different partners and stakeholders in amongst that sort of decision, the scoping, the forming exercise. What's your learning been in that space?
I'm going to give my bit, and I have Robin on the call who's also can jump in and join, put her opinion as well. I think going from a multi-agency point of view, it allows you to consider so many things that maybe from the data side of things you have maybe blindsided to. So being able to get the requirements or gather the requirement from different people, DHSC, local government authorities, they may be able to say the burdens or show the burdens that, you know, you may not see, give some factors that you may not see as well, and also give a more rounded approach rather than us just going off with the data and, you know, saying just the insight that we find on it. So because in terms of working with data, we have a lot of publications and collections that some are for the blind, some are for the you know, guardianship, some are just for mental health. So being able to work with different agencies allows for a more rounded and better representation. I think that's one thing I've learned. The only side effect to that is you really can't please everybody. They may have like suggestions or things they may want to be put on the front burner, but that's not always priority at the same time. We're not able to mix up or match with the requirements, the deadlines, because a lot of stakeholders are involved. I know one of the recent asks from one of the agencies is if we can, you know, submit data a lot earlier and reduce the timelines. It's something we're working towards, but what's the impact that this is going to have on the local authorities, because they're in charge of collecting the data. So even if I want to say, oh yeah, I'm very happy to give you the data tomorrow or next month, I need to consider, okay, local authorities, and we have like over 100 of them. So how does this work for you? So having that roundtable discussion makes sure that when we make decisions, everybody's opinion, everybody's view is considered. It may not necessarily be acted upon at the same time, but it needs to be considered. So I think that's my take on it.
Thank you very much. And maybe if I can come for the same question to Sophie, Sara and Isobel, well, that was a mouthful. Just your thoughts, because already you displayed through your presentation that multi-agency approach, but if there was one or two things to share with us about your learning and pitfalls to avoid, yes.
So are you happy to cover this with your work on engaging with various stakeholders?
Yeah, sure. So we're currently in the middle of our engagement session with various stakeholders, yeah, I completely agree with what was said before about it is having that roundtable discussion and making sure that everyone has kind of an equal say in where we go moving forward. I think it is definitely a really big challenge to get people to agree on, what data does need to be collected, because there's so many different needs. But what we're trying to do is develop that core data set and those core definitions, and then hopefully people can add to them and build on that. But yeah, having that core initial start is what's really important.
Great, thank you very much, Sarah. I'm going to jump into some of the more bespoke questions now, but if I can ask speakers to, while they are welcome to come in and talk, just to think about any learnings that they've had around the multi-agency approach as well from across the nations. So,
could I just add a little bit on about?
Of course you can, Richard. Please come in.
It's something I do feel a little passionate about. And it's because I've worked in field sales for a while when I was younger. I did 3 years in field sales. And what I feel is that we don't sell the idea to people. So a key thing when you're selling something, you've got to get someone to buy in the what's in it for them. If they don't get that, they won't do it. And I think we ask and ask and ask people to do things, but they don't understand the benefit. And I think we need more effort into helping them understand how we can help them.
Great, Richard. I think you've got lots of furious nods just as you were saying that. So thank you very much. And again, this is a bit of a dialogue. So please, if you want to come in and say something, you don't need to be invited. Just do jump in. So just going on to a few other things as well, if that's okay. There's been a lot of chat focused around, how we get in and involved in some of this work as well. And thank you very much for those that have shared links and also have taken some actions offline as well to share some of those processes to get involved. But if I can maybe come, Sophie, to yourself, Sophie John, that is it, to yourself. So I know you've answered some of these questions, but I'm going to ask one or two of them if you don't mind, for those especially that haven't been able to see some of the chat. And there was a question raised by Madhavi, and hopefully I'm pronouncing that right. And she was talking about the census between 2011 and 2021 and flagging some of the CQC linked data to indicate when people enter a care home. And I know you've responded to that, but just for those that can't see the chat, Sophie, would you be able just to kind of share what you've put in there? That'd be super. Thank you.
Yeah, of course. So as part of the piece that I mentioned, kind of thinking about how we can track people's movement in and out of care, one of the things that we need to be able to do is identify people outside of the 2 census time points. And we're currently working on creating a flag using some of the other data which I presented earlier, which is linked in our public health data asset, to try and create a flag to be able to do this. I think the question was in relation to, it mentioned CQC individual level data, which we don't currently have at ONS. We have some aggregate level data from the provider information returns that we get. But yeah, we're currently exploring other ways so that we can hopefully identify individuals between censuses, and then we'll be able to track movement in and out of care, but also, movement in and out of hospitals, access to GP services, mental health services, and things like that. So it's kind of a big project, and we're only in the initial stages of scoping out how we can do it. But using the the linked data that we have available is kind of key, really, and something that we're keen on doing more and more where possible is linking data. There's issues obviously around that in terms of governance and getting data in and the amount of time it can take to link certain data sets together, but that's part of our plans going forward. And can I just pick up slightly on your question in return to like multi-agency working, because you talked a little bit about impact, and I mentioned in my presentation some work that we started initially last year on self-funders, and that was using the CQC data that I mentioned. And when we started that work, it was completely new to us, and we worked with a number of different organisations that formed, I suppose, like an advisory group of experts, and there were people there from central, local government, academia, charities. So some of those people are here today, and they helped on different aspects of work. And I think I listed some of the organisations on the slide, but from like methods to understanding the data to the policy context and just understanding more about exactly who self-funders are. And thinking about impact, we work quite closely with DHSC on this work and how it can potentially feed into their funding allocations as well going forward. So it's really important that kind of the data that we do, is important for policy and other purposes as well. Yeah, sorry, just to go back to that one. I think you're on mute. Classic.
One of us had to do that today. One of us had to do that today, so it was me. But no, I'm loving this generative conversation, and so I'm going to travel all the way up north now, David. I'm going to come to you, and Lewis, thank you very much. I know it's that I'm giving you 30 seconds just to prepare with some of my banter there. So no, so my question, well, not my question, another question that's posted today in the chat. You talked about the National Care Service, and I'm conscious, there's been a lot of acronyms used today as well. So what we'll try and do, working with the speakers for everybody today, is try to explain some of those acronyms as well when we do the report out. So you talked about the National Care Service, and there's a question put in today talking about, or asking, will the evidence-based reports from the National Care Service bill be published? Now, it might be too early around that, but David, is there anything more you can share and where you are in that process?
I must say I don't know the answer to that. I would imagine there will be. In support of a bill, it would normally go out. In terms of the things that I've seen, it's from published statistics. So in terms of the evidence papers, so I can certainly get back to you on that one, or post it in. I think then it said when we put out make the papers available or whatever, I can provide more information on that. That'd be helpful.
Oh, that'd be great. And I know, David, there's some links about the National Care Service and the consultation, so maybe some of that might help stir some thinking with some of our participants.
I think, yeah, the publication, has links. So.
Okay, I'm going to move now across the waters. Aideen, coming to yourself, if that's okay. So thank you very much. Thank you for the spin on the presentation and moving into children and young people. So that was really helpful. I mean, I've got lots of questions, but I'm not going to use Chair's prerogative and ask them. I'm going to go to those that were posted. And Silje Sikar posted one, and she was, and while you were talking, and this might actually be applicable for others as well, but maybe you want to kickstart some of the comments on this, is she asked if there's data from ambulance service including in the data. Sometimes with mental health incidents, patients are not admitted to A&E in hospital. Just some thoughts and reflections on that, and then I might open up to others as well. Thank you.
Yeah, absolutely. I was just actually typing a response to that before you called me in, so this saves me typing. Unfortunately, the short answer is no. Unfortunately, we don't have ambulance service data right now. But I think when you're trying to use administrative data to measure mental health, there's a range of pitfalls and sort of limitations with it. We're limited to hospital presentations, hospital admissions, prescription medication, and mortality data. So, we're missing things like referrals to alternative therapies, and anyone that doesn't go to seek help and seeks help privately themselves. But what I would say is that we're working towards improving the data that's available within that data warehouse that I mentioned in the Honest Broker service. So the ambulance service data we are requesting. We are also requesting what's within that Paris system that now SOSCARE has moved into. That contains your mental health services data. So if you go see a GP and you're referred to a psychologist, and there'll be a flag on that Paris system that says you've been referred. We'll not know what treatment you received, but we'll know that you've been referred. But it's about, like I think Richard mentioned, proving that this is useful to individuals. So I think going out and presenting our results, and within the Department of Health, we worked directly with them and started to show the utility of administrative data and what it can do, and really having them pushing from the top down, saying let's make more data available is what's helping open this up in Northern Ireland. I suppose we're lucky because we are a bit of a smaller country, and it's easy for me to know who the head of the Department of Health is here. It's slightly different in larger countries, but I went off a little bit off topic there. Short answer, no, we don't have ambulance service data yet. Long answer, we're hoping to get it soon.
Great, thank you very much. And I guess one of the things even in Scotland we're trying to do is do that linkage across that multi-agency approach. David, your hand shot up, and is it because I said Scotland and you felt you had to come on?
Yeah, I thought no. Thankfully, someone in the team is on the call and has come back to say yes, the evidence papers are being published. They're being published in June.
Oh, fabulous, Dave. There we
and
go.
I can put the exact date when I forward it on later on.
Oh, thank you, David. And if you can add the link on as well, that'd be great, and we'll share on the report. Super. Aideen, thank you very much for that. And I guess I was just kind of reflecting on, I think we're all across the nations in that sort of journey. We've got data, now it's getting the protocols to share and link that data to derive more insights. Okay, I'm gonna move to a question that was raised by Heather King. So Heather, thank you very much. Thank you to everybody for, and questions are still coming in. A massive shout out again to Robin Wilson in the background, who seems to be responding faster than the questions are coming in. So thank you for that, Robin. So Heather poses the question, Ojoyi, it's just for yourself, and it was when you were talking about the digital landscape. And our question is, as a local authority, they find it difficult to get the data into the right format for any sort of data return. And it was the question with a comment, and she's welcoming the automation journey that you talked about. Is there any way people can learn more about that or contribute to that journey as you're developing it from a digital front? Ojoyi.
Yeah, really good question. Thank you so much. When I talk about the automation, I mean, we're trying to make life easy for everybody working on the adult social care data. In the meantime, the automation is mostly around our processes to see how we can streamline things and avoid people manually doing a lot of stuff. We're currently starting off with our publications and the collections from this side of things, but it's going to be an interesting or one we can also look into in terms of the local authorities to see how we can automate the process to make it as easy as possible. We believe it's going to be a ripple effect that when we automate our processes, would need to also do that for people who are submitting from the local authority. So of course, that's something we're going to take on board. Currently, if anyone's having any sort of issues with getting the data in the format, we do offer any sort of help. We can jump on Teams calls to make sure that we're talking you through the process, or send you like webinar slides we've done in the past. We also have a mailbox that's opened 24/7 where we can have you can send in any sort of questions. We can book a Teams meeting to get that resolved. But in terms of the future, that is something we have in scope as well, to see how we can minimize any manual labor that goes into your analytical time. I hope that helps.
No, it certainly does. Thank you very much, Ojoyi. And then Richard just put his hand up as well. Richard, please do come in.
Yeah, so this is from experience with dealing with the adult social care finance return, and it's with the short-term data that was collected. Now, the reporting was in weeks, and then it was asked for the local authorities to report in hours. And this is where the data started to lose its value. Because if I asked now everybody on this call, how many hours are in a week, I would imagine we'd get a multiple of different options. You know, civil servants will say 37, people in working in catering 45, people in caring doing 12-hour days 60, 24-hour service will be 168. not everybody got the memo that it was weeks to hours, so it was multiplied by 1. And I looked and looked to see if there was guidance, to see if anyone was told this is how many hours is in a week, but there was nothing there. And I think it's the fundamentals sometimes that we don't quite get right, because we assume that people know what's in our minds, but what we really need to be, we need to be absolutely explicit on what we're trying to capture.
Yeah, I think that's a really fabulous point that Richard has put out there. And I think I saw on one of the slides, the lack of standardization, like bringing that, standardization across board and making it as explicit as possible is something, we need to work on different fronts, different agencies. And it's something would also be taken on board as well as one of our priorities this financial year.
Great, super. Speakers, I'm going to give you a break, but I'm not going to let you go without asking one final question to everybody. And I know a few of you haven't had a chance to speak, so I'm going to come to you first. So Sarah, I'm going to get you to kickstart this for us, if you don't mind. My question for you, and I appreciate firstly, there's lots of questions that we haven't managed to answer because of the timing. So we will be circulating this to yourselves, and I know in past webinars similar to what we've done before, you will support us in getting the questions out, and we'll build that into the report out. So just some assurance to all the participants that have raised wonderful questions. We'll make sure every single one is answered, as well as sharing what's already been answered as well. But Sarah, coming to you. This has been a really, really interesting journey for everybody across the nations. We're sharing individually across teams. We're sharing not just nationally, but internationally. But if I can ask all the speakers, and Sarah's going to kickstart this for us, is there been one piece of evidence or research or work or a document or a paper that's really helped you in your journey? Now, it might be a few, and you might want to list a few, but has it been one piece that you've read and you thought, that's my aha moment, or that's just helped me connect a little bit more across what am I doing? And if there isn't one, that's okay, I'm not putting you on the spot, but I guess it's about just helping us and all the participants to think about, the reading and the literature and the research that's around us. Where do you go for your bouts of inspiration? So, Sarah, hopefully that's not too difficult of a question, but what would you throw into the mix?
Was that for me? I'm conscious there's multiple.
Sarah, it is. Sarah, sorry, apologies. There is. It's for you.
For me? Okay, perfect. Thank you. It's such a tricky question to get me to start on. But I think the first one I saw has got to be the OSR review, because, it did show what needs to change, and that there does need to be a lot of work from multiple people across the sector. But I also love reading the National Care Forum blogs, because it's just, you get how people are feeling on the front line about, what is the value in the information, what's missing, get gaps that we won't see because we are kind of sitting in our ivory tower, I guess, to be a little bit cynical. But I love seeing that and hearing exactly what they want from us. And it's encouraging that they do want more data, because some people hear data and shut down. It's a bit boring. But yeah, I think those two.
Thank you, Sarah. I'm furiously writing this down. And data and boring, how dare they? How dare they? Lewis, I'm going to come to you next. What would you throw into the mix here?
Yeah, I would probably say ditto on the OSR report. But in Scotland, we've obviously had the benefit of what David called the Freely report as well, which really puts into stark contrast the kind of challenge that we face. And again, I pay close attention to reports specifically on data that Scottish Care publish about whole systems approaches and the different methods that we could be employing.
Great, Lewis. And I'm going to ask all the speakers, once we do the report out, to share these links with us, and we'll share with the participants. Isobel, coming to you, what would you like to throw in? Anything additional?
I think coming from client level data, from the, speaking to people, working with local authorities, it's really getting that individual kind of perspective that these are real people, this line of care journey, that's someone's journey to wherever it ends or starts. And like Sara said, taking that into account and really knowing that whilst we're working with the data, I think is how we're going to get the best out of it. And I'm sure everyone from DHSC is in the agreement that we're very much conscious of that there's people behind this, and yeah, just kind of working with people and getting those discussions going has been something really helpful in learning that perspective. Yeah.
Oh, thank you very much, Isobel. Sophie B, coming to you.
Thanks. So I was also going to say the OSR review in terms of like a published document that is a bit of that revelation of actually what is going wrong. But if I was to say something else, it's not something that's published, but so when I joined the department, we were using a capacity tracker as our main source of information to know what was happening in care homes. And my first kind of understanding of it was a national government perspective of this is a great tool that is getting all the data that we want daily, and it's helping us kind of respond to the crisis. And then a few months later, I then went to my first kind of stakeholder engagement meeting where we have representatives of these providers, and it was a completely different picture. Loads of arguments that I had never heard before, and it really put that in perspective to understand how actually, what is a great tool for national government needs might not be for other stakeholders in the sector. So that was a bit of my kind of epiphany moment of understanding that it's a lot more complicated than what I initially thought.
Great. And I see Deana's just came on as well. So we've got probably 1 minute to do the next couple. So I'm going to ask you to do 10, 15 seconds of a quick update. Sophie J, though, I feel like I need to go into the Spice Girls there. Sophie B, Sophie J. But Sophie J, over to you.
Sophie and I have that a lot in meetings when we're in together. So I'm going to jump on the bandwagon and say the OSR review. But the reason is our team, so there wasn't a social care analysis team in ONS until the OSR report was produced. So it's kind of the reason that my post and my team and the work that we do exists. So that's got to be key, really, for me.
Oh, thank you, Sophie. Aideen, coming to you. What would you like to add in here?
I'm just going to go quite broad in that government strategies, I think, are my sort of source of motivation and ideas, and that we'll look at, in particular, the Department of Health strategy, Department of Health in Northern Ireland recently had a new strategy for care experienced children. And you look through that and think, well, within this, where can administrative data research help to answer questions, help to benchmark, help to quantify or inform? And currently, Northern Ireland Children's Care Services is going under a independent review, so it'll be interesting to read that in the coming years. But government strategies I never read until about 5 years ago, and they're actually useful to inform research questions.
Okay, thank you. I had a wee chuckle there. David, coming to you next.
Yeah, unfortunately, I'm probably going to go with the OSR report and the Feely report. I would add, as well as the main body of the Feely report, the consultation responses are also very useful in understanding the feedback from other organisations and getting a lot of their thoughts around the direction of any national care service is very useful. There's also a data landscaping. It's unpublished at the moment, but it hopefully will be published, which for somebody new like myself to the area sets out very nicely all the current data sources, which is very useful to have in one place.
Great, thank you very much, David, for that. Ojoyi, over to yourself.
Thank you. I think I'll go the OSR review, like everyone has said, but just not to be cliche, something that has really stood out to me, because I'm actually new in the area as well, is a conference I went for a few weeks ago, I believe, about data-driven lives by Tableau Salesforce, and being able to see how the data that we do, the data we churn and tackle every other day is affecting actual lives and people. I think that was an epiphany moment for me, that we're not just dealing with objects or numbers, but actual human beings, and seeing the impact of what we do in their lives. So I think that was like, wow, I think I really like, I like what I do.
Oh, great. And that links to what Isobel was saying. And Richard, leaving the best to last before I hand over to Deana.
So Ojoyi, I'm very similar to that. So because I know elderly people and working age people in receipt of care, when I started working with adult social care at the ONS, it was the first time that I felt that I wasn't working with data. I felt that I was working with people's lives. And when you feel like you're working with people's lives, you really do step up the game, and you work a lot harder because you know that what you do could impact their futures.
Oh, thank you, Richard. Deana, I've been a terrible chair of the Q&A. Apologies, but I've thoroughly enjoyed listening to all our speakers. I'll hand to you to close us off. Thank you, Deana.
Okay, thank you so much. And we have run slightly over time, so I will be quite quick here, even with this extended time period. Thank you tremendously to all the speakers, but also to all the support team and to the participants. Obviously, lots of really interesting questions coming in. Just reinforcing that any questions, anything put in the chat that hasn't been responded to, we will be capturing and then sharing with the speakers, so you have an opportunity to make a few additional comments, and that'll go into the report. It does seem that some kind of follow-up discussion in 6 months or so would be really useful, because there's so much going on and some of this is really quite new. So hopefully we'll be able to think about doing something else. In terms of looking forward, it was very interesting that in the Q&A, so many of the comments seem to relate to the engagement and the discussion between the people collecting the data, the people using it, and the impact. And our next webinar, which is going to be probably the end of June, there'll be a note coming out very soon on that, is around the health and care themes and the work that's been done within each area, but with a particular focus on how to facilitate and enable discussions between the providers and the users and the people working with the data, which may be different in different areas of health and care stats. So a lot of what's been said in this discussion, I think, feeds very much into that and picks up how do you actually enable that discussions which helps you take forward the improvement with the data and improvement with the analysis. So look out for that. We will be putting that on the our usual circulation and on the HSUG web pages, and hopefully you'll be interested to come in and contributing to that. But without taking up any more time, because we are now 4 minutes over time, I would like to say once again, thank you very much to everybody. Any further thoughts, please email them in to us. Happy to continue the discussions afterwards. But thank you, and enjoy the rest of your day and your week. Very much appreciated. Thank you.